Welcome to my presentation titled Floating the PIE Exam. My name is Michael Fuller. I'm a senior radiographer and clinical educator at Flinders Medical Centre in South Australia. Just to make sense of this title, we now refer to commenting by the acronym PIE. It's worth noting that this video is about 20 minutes in length. This is what I'm going to be talking about for the next 20 minutes. What is PIE seems like a good launch pad for this presentation. So what is PIE? PIE is an acronym. The acronym is shorthand for Preliminary Image Evaluation. You may have heard the term commenting before. Commenting and PIE are the same thing. They're interchangeable terms. So PIE refers to the practice in which radiographers flag acute pathological appearances via a short written comment at the time of an X-ray examination. Now, this could be recorded as, for example, a PACS note that would be seen by the referrer and will provide a timely alert to the referrer and a short description of an acute pathological finding. I'm going to take a step backwards to provide some historical context to PIE by taking a look at its predecessor, the red dot system. This is Northwick Park Hospital and Clinical Research Centre, and this is where it all started. This is quite nostalgic for me, looking at this photograph, because this is the first hospital I worked in as a base grade radiographer back in 1982. PIE, or commenting, was a refinement of the red dot system, which was a term coined by Dr. Lowell Berman and his colleagues at Northwick Park Hospital. The red dot system arose from a concern at Northwick Park Hospital regarding the number of patients with missed plain film pathology in the emergency department. A system was conceived in which radiographers flagged acutely abnormal X-ray findings at the time of the examination by sticking a physical red dot label on the patient's X-ray folder. The trial results were published in the prestigious BMJ, the British Medical Journal, and this process was adopted more widely across the United Kingdom. Despite all of its promise to improve patient care in the emergency department, the red dot system had its shortcomings, and I will discuss these next. The red dot system did have its shortcomings, and I just wanted to look at a few of these now. There is an assumption that the doctor who is looking at the images is seeing the same pathology as the radiographer, and there is no guarantee that that is the case. There's also an assumption that the absence of a radiographer's red dot indicates no abnormality. Well, that's not necessarily the case either. The absence of a red dot might mean that the radiographer had simply forgotten to add a red dot. There's also an assumption that the doctors who are referring patients are actually aware of how the red dot system works. And once again, if it's not reinforced in the orientation process, the referrers may not be aware of how the system works. And importantly, the system does not allow for multiple pathologies, and multiple pathologies are not uncommon. So what does commenting, or PIE, look like in Australia? My first introduction to the concept of commenting, or PIE as we now know it, was at a workshop at the Royal Brisbane Hospital. This workshop was presented by Professor Marianne Hardy and Professor Bev Snaith. This was a wonderful eye-opening two-day workshop providing an introduction to commenting as it was being practiced in the UK. In this slide, I'm going to be talking about what commenting is, and in the next slide, I'll be talking about what it isn't. Commenting is radiographers describing acute abnormalities on X-ray images. There is a strong preference for the use of simple, basic language. The referrer will often not need the detail, which you would find in a radiologist's report, to make that initial treatment decision. In some cases, you may find that you're simply providing a description, not a diagnosis. So, for example, if the patient had a cortical disruption or a cortical irregularity and you weren't exactly sure of the significance of it, you would simply describe what you saw. And importantly, The patient will benefit from this timely identification of abnormalities on X-ray images. Now I'm going to talk about what commenting isn't. So radiographers are not trying to produce a definitive report. That is the role of the radiologist. We're also not trying to be elitist. So there are pathologies that are named after people. These are referred to as eponyms. And there is an assumption when you use an eponym that you understand what the eponym means and the referring doctor understands what the eponym name means. And that is not always the case. The medical officer, the referrer, simply wants to know whether he or she needs to provide treatment. So why commenting? I've already addressed this, but I want to expand on this a little. The radiographer in the emergency department is in a unique position. There are no other professions that are able to do what we do. The radiographer sees the patient, can ask the patient about their presentation and correlate this information with the initial routine X-ray images. Where there is equivocal evidence of acute pathology, we can perform additional views that will have the potential to confirm the existence of a subtle acute pathology. Having been through this process, it is entirely reasonable for the radiographer to pass this information via a PIE comment to the referrer. This is not a long stretch of the bow. Finally, it's worth emphasising the radiographers are licensed to produce X-ray images. There is no other profession that has the skills and the licensing to do what we do. Now I want to talk about commenting and ASMIRT. Back in 2016, ASMIRT established a commenting project steering committee. If we look down at point 1.4 below, one of the aims of the steering committee was to establish a certification process. And that process has emerged in the form of an ASMIRT certification exam, which is what this presentation is all about. So I just wanted to give you some information about the ASMIRT PIE certification exam. This will be an online supervised exam. You'll be sitting the exam typically in a room with other people. It will cover emergency department and ICU patients. The exam is 3 hours in duration. There are 75 cases to consider, and the exam will include normal anatomy, and it's often the normal anatomy cases that are the most challenging, upper and lower limb, spine, pneumothorax and mediastinum, soft tissue signs, and incorrectly positioned chest lines and tubes. Now, they could be ED patients or intensive care unit patients. And if you want more information about the types of cases that you're going to see, there is further information on the ASMIRT website. As I've just mentioned, there is further information about the ASMIRT PIE certification exam on the ASMIRT website. If you want a quick way of getting there, if you type PIE and ASMIRT into the Google search engine, your first link will take you to the page where all the ASMIRT certification exams are detailed. And if you scroll down the page, you'll find the PIE certification exam information. It's noteworthy that for ASMIRT financial members, the cost of the exam is subsidised at the level of $229, which is a very reasonable fee for sitting the exam. So you've signed up for your PIE exam, you've started the online exam, and after reading through a preamble and a few important instructions, you will start your first case, and the layout will look like this. On the left-hand side of the screen, you have a patient history and a number of images. And on the right-hand side of the screen, you will have some pull-down boxes from which you'll make your selections. So the initial question for each candidate will be to determine whether the case is normal or abnormal. And from my experience, I find that declaring a case to be normal a lot more difficult than declaring it to be abnormal. So having decided that your case is abnormal, you will have to make some selections from 4 drop-down menus. And it was necessary to make these menus contextual. So The menus that you'll choose from for, say, a distal radius fracture will be different to the menu that you'll see with, say, an ICU chest X-ray. Now, ASMIRT have contracted the company Pearson VUE to run the PIE certification exam. You may find the PIE exam is combined with other ASMIRT certification exams, so the person sitting next to you may be sitting, for example, the CT certification exam. The examiners will allow you up to 3 hours to complete the exam, and it's important that you bring along photo ID and your examination registration details. You need to bring these with you to sit the exam. Now I wanted to make some suggestions about how you might prepare for your PIE exam. So I wanted to make some suggestions about how you could prepare for your PIE exam. If you're in an isolated area, you're going to have to engage in self-directed learning. Unfortunately, at this time, there's plenty of material on the internet which you can use. If you're in a large department, you might want to consider having education sessions directed at the PIE exam, and I thought of 3 different ways you could do this. You could have didactic education where one of your radiographers chooses, say, a joint, the hip joint, and presents on the pathology, identifying pathology in hip radiographs and how you would describe those pathologies. You could also have regular case review meetings where you, say, have a folder in RIS where you collect suitable PIE cases and you periodically review those, how you identify the pathologies and how they're described. And if anyone's particularly motivated, they could set up a practice exam where you have a typical, what you might expect to find in the PIE exam, and possibly a format of PIE exam type format of how you describe the pathologies. I'd also suggest that there is a case for training at a higher level than the ASMIRT exam, or perhaps another way of putting it is looking at information sort of around the edges. Now, the reason I suggest this is that if you are commenting, it's likely that there will be occasions where the referring doctor will come back to you and ask you questions about a case. And I really think to have a good conversation with the referrer, you need to have all the information on board. So that's a personal view that training at a higher level than the ASMIRT PIE exam, there is a case for it. I would strongly recommend that before sitting the PIE exam that you are well versed in a search strategy. Now, this is a typical ABCs type search strategy, and you'll find there's plenty of information on these on the internet. You may also want to consider whether you set up a search strategy that is specifically directed at the PIE exam, and I've made one suggestion here. So this is the LBJ's search strategy. People from my generation would identify with this acronym. Lyndon Baines Johnson, the American president, was often referred to as LBJ. And the search strategy starts with L, lines and tubes. Now this is only going to be appropriate for chest x-rays. Under bones, I've got another acronym here, COLT, cortical outlines, opacities, lucencies, and trabecular. Joints, and then soft tissues and satisfaction of search. It's worth noting that there could be more than one pathology in each case. And under soft tissues, you're going to need another memory aid because if you're looking at a chest x-ray, you'll be looking for pneumothorax and pneumomediastinum as well. So I want to have a look at what other organisations think of PIE. The Royal Australian and New Zealand College of Radiologists, RANZCA, put out a position statement a few years back which looked at the subject of radiographers engaging in image interpretation. Now, you could read this document if you want to understand the detailed position of RANZCA, or you could just read the title, which provides a good summary. Needless to say, the radiologists are not championing the introduction of PIE in Australia and New Zealand. Now, I should put a rider on that. I should point out that the radiologist's professional body might not be championing the introduction of PIE, But PIE is being at least tolerated by radiologists in some hospitals in Australia that have been running a PIE service for some years now. Though this is a more recent article from a Ransker newsletter, and the position of Ransker on radiographer image interpretation appears to be unchanged. Similarly, if you don't want to read the article, the title provides a good summary. I will move on to the MRPBA, which is the registration body for radiographers in Australia. So these quotes are taken from the Professional Capabilities document, which is dated March 2020. The first quote is that taking appropriate and timely action is a key responsibility if a medical radiation practitioner identifies medically significant findings on an image. So the MRPBA is going a lot further than tolerating radiographer image interpretation. Indeed, they are making it a key responsibility for radiographers to act upon the medically significant findings on images. This is sometimes expressed by that wonderfully succinct aphorism, if you see something, say something. The MRPBA goes further in the Professional Capabilities document, where it states that medical radiation practitioners must ensure that information is conveyed to and understood by the appropriate persons, who may include the reporting medical specialist, the requesting practitioner, or other practitioners. So the position of the MRPBA in relation to radiographer image interpretation is clear. It's noteworthy that you will need to read the relevant section of the MRPBA document to consider these quotes in their full context. So what does the UK College of Radiographers think of PIE? Well, I've got a quote here from a paper by Mary Ann Hardy and Gary Colpin back in 2007. And in their paper, they have stated that the College of Radiographers has called for red dot schemes to evolve and has recommended the development of radiographer commenting. And my understanding is that this has continued to this day, and commenting in the UK is very common. A proposal to introduce PIE into an emergency department is probably going to be received well by the emergency department doctor. So what do ED doctors think of PIE? Good, I think. This is based on previous experience of introducing the predecessor, the red dot system, and from the ED doctor's point of view, having another set of eyes looking at plain film images was a good thing, and they were all for it. So I'm going to use Queensland Health as an example of one state government health department's approach to credentialing radiographers to engage in commenting. So from this document, which is a few years old, and you might want to look at more current documents, but at the time, the Queensland Health had the following to say about credentialing of individual radiographers. So radiographers providing written comment on plain X-rays will be registered with the MRPBA. Credentialing of individual radiographers is not required. Local radiographer managers will ensure individuals are competent through performance appraisal and development processes. So the way that I interpret this is that radiographer commenting is within our scope of practice, and it is up to individual sites to ensure that the radiographers are appropriately trained to engage in commenting. So will I ever be able to comment at work? I don't know. I think the best approach is baby steps. Just because you've passed your commenting exam does not guarantee that you'll be able to comment. There is likely to be a lot of stakeholder consultation before a commenting service is provided. So is it worth undertaking the PIE exam if your department doesn't currently allow commenting? Well, I just wanted to consider worst case scenarios. So in my view, the worst case scenario, having trained for your PIE exam and passed the exam, is that you become a better radiographer. I think that when you are imaging in the emergency department, You can approach it two different ways. You can image anatomy or you can image pathology. And I think you're a better radiographer when you're imaging pathology than when you're simply imaging anatomy. I think a legacy of this is that you will find your job more interesting. You're producing images and you understand what you're looking at. You can also engage in conversation with your clinicians around you, with other members of the clinical team, using correct terminology. Another subtle benefit of having these skills on board is knowing when to repeat and when not to repeat. And finally, if you've passed your PIE exam, you've lost $230. So this is a bit of a financial worst case scenario for you. Now I want to consider accountability and legal responsibilities. I wanted to have a look at the legal status of the radiographer PIE comment. I think it'd be fair to say that you're legally accountable for everything that you do and say in your work role, and I think it'd be difficult to make a case to the contrary. Now, if you're running a red dot system, it's likely that the legal accountability of PIE is going to be on a par with red dot. So if you weren't having legal accountability issues with red dot, you're probably not going to have them with PIE. It's also worth bearing in mind that radiologists are about 97% accurate at best in their reports, and you are probably going to achieve a level that would be on par with that. And I've just put a quote in here if you're interested in doing some further reading. Now, the next thing I wanted to look at was whether PIE in itself was considered to be advanced practice. So is PIE advanced practice? No discussion. PIE is not advanced practice. If you are wanting to apply for status as an advanced practitioner, I would advise you to consider the process that is outlined by ASMIRT on their website. So thank you for seeing this video through to the end. I have provided a lot of historical and other information leading to the establishment of ASMIRT's PIE exam. But I would argue that the additional information does place PIE in its historical context and its Australian context and its international context. I think at this point, if you have any questions about the ASMIRT PIE exam, they are best directed to ASMIRT, and the ASMIRT website would be a very good place to start. Happy commenting.